Good evening, everyone. Thank you for joining today's masterclass on management of upper GI bleeding. I am Priyanka Jain from the Marketing Department, Elsevier, India, and me and my colleague Kritika Monga will be moderating the session today. Before we move forward, please note that all the attendees here will stay on mute during the entire session. So whatever questions you have, please post them only in the Q&A tab on your screen. Your questions will be addressed by our speaker at the end of the session. Also, there will be a few interesting MCQ questions that will be asked from you in between the session. These MCQs will appear on your screen for around 30 seconds, after which we will show the result. The participation in this is anonymous, so feel free to submit your answer. And now, I would like to take this opportunity to introduce our esteemed speaker of the day, Dr. Ian Penman. Dr. Ian is a consultant gastroenterologist at the Royal Infirmary of Edinburgh in Scotland. He got trained in medicine at the University of Glasgow and then undertook postgraduate training in Glasgow, Edinburgh, and Charleston, USA. He has special interest in advanced endoscopy, especially interventional EUS and the therapy of Barrett's esophagus and early esophageal neoplasia. He is currently the Vice President of British Society of Gastroenterology and the Chair of Endoscopy Committee. Dr. Ian Penman's association with the Davidson's Principles and Practice of Medicine goes back almost 25 years. He was author of the Gastroenterology chapter of the 18th till the 22nd edition and also has been one of the book's co-editors for the 22nd and 23rd edition. We welcome you, Dr. Ian. It's an absolute honor to have you with us today. Over to you to take the session forward.
Well, thank you very much, Priyanka and Kritika. My thanks to you and to everybody at Elsevier India for this kind invitation. It's a real privilege to join you today. We have a lot to cover, and forgive me if I go through this quite quickly, but this session is being recorded and you have the ability to see the whole lecture offline later. So I hope you can see my slides. I work at the Royal Infirmary, which is an old hospital. It's been there a long time, a couple of 100 years, and it's been knocked down and rebuilt several times. And on the bottom left, you can see our latest development that just opened a few months ago. It's a 1,200 bed acute hospital dealing with all specialties. And Sir Stanley Davidson, who is the editor of Davidson's, or was the professor of medicine in the city where I work, and first published his book 50, 60 years ago based on his own lecture notes. But as you can see, the book is very, very different today, but the ethos of excellence in medicine and medical teaching lives on. I've had the real privilege of visiting India with Elsevier many times. I've been to quite a few different cities, from Mangalore in the southwest to Chandigarh in the north to Lucknow and Patna in the north and east. And it's a great shame that coronavirus has stopped us traveling, but I do hope that one day soon I'll be able to come back and visit many of you again. I really enjoyed every time I come. So in my talk, we're going to have a sort of lecture about upper GI bleeding and its management, and then hopefully illustrate it with a case. And then have some Q&A at the end if time permits. So why is bleeding important? Well, it's common. And despite advances in the technology and in therapy over the last 20, 30 years, it still has an overall mortality rate of about 10%. And bear in mind that that mortality rate is even higher if patients have a bleed while they're in hospital for another reason. For example, if they come in with a stroke or pneumonia, or they have an elective hip operation and then have a bleed, their chances of dying are much higher. Bleeding is increasingly seen in elderly patients who may have a lot of comorbidities, and also around the world through hepatitis B and C, through alcohol and drug use. Liver disease is getting more and more common, and we're going to see more and more variceal bleeding in the years to come. So there are many different causes of GI bleeding. This is a picture taken from Elsevier, but I would highlight that, peptic ulcers cause about 1/3 to 1/2 of acute upper GI bleeds. Erosions of the lining of the stomach and esophagus, so esophagitis, gastritis, account for quite a lot more. And varices. Varices count for somewhere between 10 and 20% of upper GI bleeding. I highlight them in blue there because it's useful when we're talking about the management of upper GI bleeding to think of non-variceal bleeding, that's largely peptic ulcers and all the other causes, and variceal bleeding in separate ways because we deal with them slightly differently. The presentation is often the same, but the subtleties of how we manage them varies. So I'm going to speak about non-variceal bleeding first, and then later on we'll talk about varices. So just to show you some images, we have, this is what endoscopic imaging looks like of a Mallory Weiss tear in the mucosa here in the top left, of a duodenal ulcer top center with a little vessel in the base, of nasty reflux esophagitis top right, of some erosions bottom left, of cancer in the stomach bottom right. It's ulcerated, you can see it's bled. And then this strange but not uncommon condition in the antrum of the stomach with all these red blotches, which are sort of telangiectatic or vascular malformations in the mucosa that we call gastric antrovascular ectasia, or GAVE, or as the Americans call it, watermelon stomach, although I wouldn't buy a watermelon that looked like that. Here are some other cases. Top left, another Mallory Weiss tear, this black split in the mucosa. This is a very odd thing, top center, called a Dieulafoy lesion. It's a little artery that pokes through the mucosa, bleeds rapidly, and retracts and shrinks back in. Can be cause very brisk bleeding. It's not common, and it's often difficult to spot with an endoscope because it comes and goes, and it's not easy to see. We have another gastric cancer down here, bottom left, and then we have bleeding malformations in the AV malformations in the duodenum. So that's just a taster of the range of things that we see. Here's more of this so-called watermelon stomach. So you're presented with a patient who's had a GI bleed. How do we manage that? Well, towards the end of the talk, I'll show you a chart that you might find useful to download, which is part of a care bundle. And it's all based around the 6 R's. And I'll come to the 6-letter R's at the end. But at the beginning, the way we manage bleeding is that we assess the patient rapidly and we resuscitate them. We then try and risk stratify them. How serious has this bleed been? And what do I need to do about it right now? We refer them to specialists, we treat them, and then after we've treated them, we make a review plan, because it isn't over just because we've done an endoscopy. Okay, so let's walk through these different steps. How does bleeding present? Well, usually presents with a hematemesis, and that can be fresh red blood, it can be purple altered blood with clots, or it can be what we call coffee ground vomiting. Now, I used to hate this phrase, coffee ground vomiting, because it was given to anybody who vomited up dark brown fluid. But that can happen if you have urinary infection, food poisoning, a stroke, severe pain in your abdomen, and it doesn't imply bleeding. But actually the vomiting up of stuff that looks like black coffee is an indication of altered bleeding. So use that term carefully. It can present with melena, often with no hematemesis. The bleeding purely goes down through the GI tract and out per rectum with black tarry stool. Rarely is it red or purple. If you're referred a patient who is passing large amounts of bright red, fresh blood or purple blood per rectum, then if it's coming from an upper GI source, the stomach or the duodenum, and it's managed to get all the way through the GI tract and come out red, then it's either incredibly rapid transit, or the patient will be collapsed, hypotensive and shocked because they'll be bleeding severely. If you see a well patient whose blood pressure is normal and who's passing red or purple blood, it's probably coming from the lower GI tract, not the upper GI tract. But it can catch us out. Young, fit men, athletic men who play sport, have a low resting heart rate, very strong cardiovascular system, good heart. They can have a very brisk bleed from a duodenal ulcer and it comes out red at the lower end, and yet they look well. They're about the only group to be wary of and to be careful with. Okay. And thirdly, patients sometimes just present with hemodynamic collapse, with syncope because of low blood pressure, and with hypovolemic shock. So when we see these patients, we need to take a careful history. We need to think about, are they smokers? Are they heavy drinkers of alcohol? Do they have other risk factors or known liver disease that might mean it's a variceal bleed? Are they taking drugs which damage the GI tract, like aspirin, or non-steroidal anti-inflammatories like diclofenac or naproxen? Or are they taking antithrombotic agents, warfarin, apixaban, etc.? Do they have comorbidities? Because the bleeding, how their body responds to the bleeding and how well they cope with the insult of a bleed will depend on how good their cardiovascular fitness is and what their respiratory status is. And how fit are they? Are they elderly? Are they frail? Do they get out the house? Are they active? What is their quality of life? Because decision-making on when to endoscope them, how far to go, how aggressive to be, we need all that information. You have to examine patients. And clearly, first thing is, are they shocked? Are they conscious? Are they hypotensive? Are they tachycardic? Have they got cold vasoconstricted peripheries? That's usually a good sign of hypovolemia. Are there stigmata of liver disease? And on examination, are they tender in the epigastrium? Is there a palpable mass? Do they have hepatosplenomegaly? All of these things will help you work towards what you think is the likely underlying cause of the bleeding. So you have to assess them, and at the same time as assessing the patient, you have to resuscitate them. And the resuscitation is very simple. It's the A, B, and C of airway, breathing, circulation. You've got to get intravenous access, and probably having 2 intravenous cannulae of good size is important, so that if you need to get large volumes of fluid into the patient quickly, you can. You don't need a lot of difficult bloods off, but you need some. You need to know their electrolytes, their urea, their hemoglobin, their liver function tests, and a coagulation screen. And you need to take blood for either group and save or for cross-matching, depending on what your local hospital policy is and how badly you think the patient's bleeding. And then there is good evidence that the first thing you should do is give the patient some clear crystalloid IV fluid. Probably 500 mils over 15 minutes of either normal saline or plasmolite to bring their blood volume back up. We want to correct their hypovolemia. We want to bring their blood pressure up. We want to restore tissue perfusion, keep their kidneys in particular perfused, and prevent the patient from developing multi-organ failure because of poor tissue perfusion. We need to monitor them, and I don't know what is standard in India, but across the UK for the last few years, we've developed charts like these on the right, which are an early warning scoring system called NEWS, the National Early Warning System. And it simply measures pulse, blood pressure, oxygenation level, conscious level, and you get scored different points for each. They get added up, and if you see the total score rising from 0 to 1 to 3 to 7, you can spot that the patient is deteriorating quickly in front of you, and you can take early action. So they should be monitored using an early warning scoring system like NEWS. When you see a patient bleeding, and I was brought up 20 years ago as a junior doctor that the first thing you did was give them blood. They've lost blood, you replace the blood. And we would transfuse people lots of blood. And now we've moved very much away from that, no matter how intuitive and how instinctive it feels that we should transfuse patients. It's been recognized in recent years that if you transfuse trauma patients, cardiac surgery patients, or now we know GI bleeding patients, if you liberally transfuse them up to a hemoglobin of 100, 110, they actually have worse outcomes. They have poorer survival than if we follow a restrictive transfusion policy. So if you actually are much tougher about who you give blood to, and you only aim to replace hemoglobin up to a target of about 70 grams per litre to 90 grams per litre, you actually have lower mortality, less rebleeding. You need to use less blood with all the risks and the costs that blood cell transfusion, red cell transfusion, it comes with. The reasons for that are not clear, but you're giving people other people's blood, it's antigenic, it's pro-inflammatory, it may be prothrombotic, it does things to your immune system, and all of these may be contributing to why people who are given a lot of blood have a worse outcome. And that was shown very nicely in a Spanish trial. I'm not going to go through this, but it just shows that in this randomized trial, that if you restrict the amount of blood and who gets that blood, you have better survival. And so we now in the UK and in most European countries have a rule of not transfusing patients if their hemoglobin is greater than 80, unless other things come into play. And those other things are clearly if somebody's bleeding to death in front of you as they come into hospital, then you need to give lots of blood. And secondly, if they're frail, if they're elderly, if they have bad coronary artery disease, for example, they may not tolerate a very low hemoglobin terribly well compared to a younger, fitter adult. And therefore, you can have a more relaxed and liberal approach to giving severely ill patients, those who are elderly, those with multiple comorbidities, more blood. So you have to use your common sense here. So I've talked about assessment, I've talked about resuscitation, and while you're doing that, you being smart young doctors are all capable of multitasking. You're not only assessing the patient, and while you're talking to them and examining them, you're also putting cannulas in and you're giving them intravenous saline and you're taking bloods off. You're doing all of that. The third bit of multitasking that you're doing is you're risk assessing them. You're trying to work out how likely is this patient to need emergency intervention, like endoscopy or surgery, and how likely are they to die? And there are lots of different scoring system tools to help you with that. And being Scottish, I'm biased towards the Glasgow Blatchford score, but I think the wealth of literature out there shows that the Blatchford score is the best of all of these scores. And by using an score, you can objectively quantify not just your own end of the bed feeling, but you can objectively quantify the risk of death or the risk of needing emergency intervention. And that can allow you to decide who do I need to call the intensive care team about. If somebody's fit and well and they have a very low score, maybe I can discharge them home without needing to admit them to the hospital, etc. So it's a very useful thing to do, but it is not a substitute for common sense. You need to use your clinical skills from the end of the bed, and when you've seen lots of patients, you'll soon develop a feeling for who is well and who is sick, and that's important. So what is this so-called Blatchford score or Glasgow Blatchford score? Well, it's very simple. This table looks complicated, but it's very easy. You measure their blood pressure, you measure their pulse, you measure the patient's blood urea, you measure their hemoglobin, and you add a couple of other background factors in, and you give them points for each of these things. And so their score can range from nothing up to a total of 23. And the higher the patient's score, the greater the risk that they're going to need intervention or that they might have a bad outcome and die. So from a very simple assessment of the patient, how they presented, what their blood pressure and pulse is, and a few very quick blood tests, you can get a really good score that allows you to predict what you need to do for the patient. The key thing about the Blatchford score is that people who score 0 or 1 do not need to be admitted to hospital. They can be allowed home, and they can come back another day for an endoscopy to find out why they were vomiting or why they had coffee ground or why they may have had melena. And that is a safe thing to do. And it may be that in years to come, we can relax this even further and find out that people with a score of 2 or 3 can also avoid hospitalization. But we don't have that evidence yet. But very low score can go home, manage as an outpatient. The higher the score, the more attention you need to pay. So why do people die from upper GI bleeding? You know, 30 years ago, the mortality rate from a GI bleed was 10%. And here, 30 years later, the mortality rate is still 10%. And the reason is this: they don't really die of bleeding in yellow here. About 20% of deaths from GI bleeding are due to the bleeding itself. But 80%, 4 out of 5 who die, don't die of bleeding, they die of other things. And those other things are deterioration and decompensation of their underlying comorbidities. The cardiac disease, heart failure, respiratory failure, aspiration pneumonia, strokes, multi-organ failure, or other underlying diseases. So never forget that if you want to stop people dying from GI bleeding, you not only have to sort the bleeding out, but more importantly, you have to take care holistically of the whole patient. You have to think about their kidneys, their diabetes, their blood pressure, their cardiac function, their respiratory status. And only by optimizing all of these and preventing these from spiraling out of control will you save people's lives when they have a GI bleed. That's a key message for you. So here's a really important slide. I'm not going to go through this in detail. It doesn't need to, but it's 2 graphs from a great paper from Hong Kong about 10 years ago. So this was people came into hospital with a peptic ulcer hemorrhage. And they were treated endoscopically, and they were randomized. If they were on aspirin already when they came in, they were randomized to keep going with the aspirin or to have a placebo instead. And what you see here on the left is that all-cause mortality 6 weeks later was much higher in the people who were given placebo compared to the people who were allowed to continue their aspirin. And the same here on the right-hand graph. This is the cardiovascular deaths, heart attacks and strokes, much higher if people who were on aspirin originally when they had a bleed didn't get to keep taking their aspirin. So it sounds counterintuitive. Aspirin caused a bleeding ulcer. Of course you would want to stop the aspirin, but actually that might not be a good thing to do. In fact, it isn't a good thing to do. That's a second key message. You'll all be familiar that when patients present to hospital with an acute coronary syndrome, there is a window of time when we must dive in and do coronary intervention, give thrombolysis, or do coronary angiography and stenting to get the best outcomes. And the same with thrombolysis or thrombectomy for stroke. And you would think that diving in and doing an endoscopy within a few hours would be the right thing to do when somebody comes in with a GI bleed. But in fact, there's really very little evidence that scoping a patient ultra quickly, that is within a few hours, does any good or is of any additional benefit. We know that patients will come to harm if an endoscopy is delayed beyond 24 hours, but doing it quicker than that isn't really necessary, except when patients are exsanguinating or having terrible hemorrhage and they're frail and got lots of comorbidities, in which case it should be done within about 12 hours. It is important to spend some time resuscitating the patient, bringing their blood pressure up, re-establishing their volume status and getting their kidneys working, getting their oxygen levels up and getting them in good shape for an endoscopy. And when we do that endoscopy, we see things like this. These are duodenal ulcers, but they are all what we call clean-based. They do not have, if you can see my mouse here, I'm not sure, they do not have visible vessels, they're not actively bleeding, and they don't need active intervention. These ulcers will heal up by themselves, they have stopped bleeding, and they don't need me to do anything clever to them. In contrast with these ulcers here, where you can see in the 3 of them, this non-bleeding visible vessel poking out. This is a branch of the gastroduodenal artery, which the ulcer has eroded into and which has plugged off. And these are at quite high risk of re-bleeding. And on the bottom right panel, you can see the artery sticking out here and active ongoing bleeding. These lesions are not going to heal up by themselves, and they need endoscopic intervention to stop them bleeding and prevent them from re-bleeding. And the way we do that is twofold. We use a needle and we inject dilute epinephrine, 1 in 10,000, 1 in 100,000, around the ulcer and around the vessel. And that causes vasoconstriction and it causes tissue tamponade, raising the pressure in the wall and squeezing off the vessel. But on its own, it's not enough. When that adrenaline, that epinephrine wears off, there's a danger that the artery will open up again and start re-bleeding. So we always combine dilute adrenaline injection with either electrocautery, using a probe, like a heater probe, or with clips. And the reason for that, you can see from this histological slide here on the left, here is an ulcer. Here's a patient who underwent surgery. This is the gastroduodenal artery here on the top right panel. And here is a temporary clot overlying the top of this volcano. This ulcer on the bottom right has eroded down into an artery, and it's naive to think that we can completely stop that from bleeding just by injecting some adrenaline. We need to do something mechanical to seal off the artery, and that's either cautery, as I showed you, or clips. So here, just to show you, I hope this video plays okay. Here is a bleeding ulcer in the duodenum. You can see fresh arterial blood oozing out of it. We've washed it. And at this point, we're going to just use a needle to inject small amounts of adrenaline around it and work our way closer towards it, towards the vessel. You can see this submucosal adrenaline here causing vasoconstriction and blanching of the tissue. And we go round and inject in several places like that. Okay, so that's the first step. And I'll just pause that video there. It's just more of the same. And on the right-hand panel, we've now swapped over, and this is a heater probe where we use electrical current to heat and dry out the tissue and seal by coagulation the 2 sides of the vessel wall together. And we're just moving again round the ulcer, getting closer towards the actual vessel. And here we go with the final application, just positioning it on the vessel itself, pressing, and then delivering 15 or 20 watts of electrocautery energy. and washing ourselves off, and that is the vessel sealed. So that bleeding ulcer has now been treated. Sometimes we don't use a heater probe for different things. We have a range of these nice clips that we can, little staples we can place down the endoscope to clip off the vessel here, and this one here that we did just a few weeks ago. This is one of these Dieulafoy lesions. There's the artery in the bottom right sticking right out, and we've put this big chomp clip on top of it, and that's that sorted. Sometimes bleeding won't stop, and we actually have this rescue salvage therapy, which is an inert mineral powder developed by the American military years ago to spray on major trauma wounds to allow them to evacuate soldiers from the battlefield. Well, we now have it for endoscopy. And when everything has gone wrong and we can't stop the bleeding, we can spray this procoagulant powder onto the surface, and it will give us a day or two of time to come up with a better plan for definitive management of the bleeding. And it's available as a rescue therapy. Just occasionally, we just can't stop the bleeding, or the bleeding recurs several days after what was felt to be really good endoscopic therapy. And that's when interventional radiology is important. And it's not available in every hospital, but in large centres, this is a great treatment for people in whom endoscopy has failed. A mesenteric angiogram is done on the left panel. A catheter is placed into the hepatic artery and along into the gastroduodenal branch. And then the bleeding point is identified, and a mixture of foam and coils are injected to block off the vessel. And on the right panel here, we've endoscoped this patient the day after embolization by the radiologist, and you can even see the coils poking out the vessel into the ulcer hole itself. And this is a very good therapy that should be available in big centres for patients in whom endoscopy has failed to stop the bleeding. So we all go home and we think we've done a great job, but actually what's really important is to make the plan for what you do after the endoscopy. We know that if you give intravenous omeprazole or lansoprazole, pantoprazole, whatever, for 72 hours after endoscopic therapy, shutting off acid allows the clot to stabilize, and it allows the ulcer to start healing, and it reduces rebleeding rates, transfusion rates, and the need for surgery. So we would give them intravenous PPI for 3 days. We've got to find out if they're Helicobacter positive. That's the cause of ulcers, apart from aspirin and NSAIDs, and offer eradication therapy. We know that if we do that, the chances of a further ulcer bleed in the future go way down. We've got to counsel the patient to avoid NSAIDs if they've been taking those in the future. And we've got to come up with a plan for what we do for people and their antiplatelet agents or their anticoagulants. And we would usually do something like this. If you're on aspirin, start it again, keep it going, or if you have to stop it, restart it within a few days, 3 days. If they're on dual antiplatelet therapies, such as clopidogrel and aspirin because of stents, that's much more tricky. We would keep the aspirin going, and we would speak to the cardiologists about what to do with the clopidogrel. If they're on anticoagulants, we need to introduce them again fairly soon, between 1 and 2 weeks. But the higher the thrombotic risk, for example, someone with a metal mitral valve, you'd want to give them their warfarin or apixaban much more quickly than somebody who was on it for, I don't know, a single DVT many months or a year or two ago. And the reason is this. Again, I'm sorry to keep telling you the same message, but I think it's really important that if you take nothing else away from my talk today, that you remember this. And this graph here is another study from the Hong Kong group that shows what happens to people when you restart their aspirin or antiplatelet therapy after an ulcer bleed at different times. If you delay it 30 days, you have a significant mortality rate within the next 6 months, up to 14%. That mortality rate disappears away down if you restart the aspirin or antiplatelet agent very quickly. So you save lives. You may get some more bleeding, but we can always repeat the endoscopy and we can always stop bleeding somehow. And the way to save lives is to reintroduce the aspirin quickly. So I'm going to ask you a polling question right now. And this will test whether you've been awake or doing other things in the background. So maybe Priyanka, could you share the polling question? Here it is. In patients with acute peptic ulcer bleeding who are taking aspirin or antiplatelet agents following, say, a stroke or a heart attack, what would you do? A, stop them completely, stop them for 30 days, stop them for 14 days, change over to warfarin, or keep them going? We'll give you a few seconds to answer that easy question. I'm expecting 100% right answers. Give you a few more seconds and then we'll see what people have said. And here it comes. All right. Okay. Well done. So to half of you, correct answer is E. We would keep the antiplatelet agent going if possible. There's no evidence that changing it to warfarin or a DOAC is of any value. And as I've shown you in my earlier slides, stopping for 14 days, stopping for 30 days, or stopping permanently is associated with a poorer outcome due to cardiovascular and all-cause mortality. Okay, so here's a sort of related one. In patients, and we'll share this polling question coming up now, in patients with an acute peptic ulcer bleed and a Blatchford score of more than 2, but who are stable following resuscitation, they don't need endoscopy, or it should be done right away within 6 hours, within 12 hours, within 24 hours, or just give them intravenous omeprazole. Then they don't need an urgent upper endoscopy. What do you think? And we'll give you 30 seconds to deal with that, to respond to that. And just a few more seconds and then we'll see what people have said. Here we go. And I think Priyanka's going to share the answer. Right. Okay. Again, exactly 49%. I hope that's the same 49% that got it right the last time. So the correct answer is D. They do need an urgent upper endoscopy, but the patient is well, they're stable, and it needs to be done within 24 hours. But as I said to you, there is no benefit from doing it at 3 in the morning within 6 hours. Similarly, I wouldn't say that they don't need endoscopy. They clearly do need endoscopy. And if intravenous omeprazole doesn't take away that need to do an endoscopy and make a diagnosis, but it can be done within 24 hours. That's all I'm going to say about non-variceal bleeding. I'm going to spend just a few minutes talking about variceal bleeding. In parts of India, I know from my last couple of visits, when several medical schools and hospitals we visited, the faculty told me that varices were a much more common cause of bleeding than non-variceal. And I think that just reflects the disease burden in the local population. So you know that varices develop because blood coming up the portal vein here from the intestines cannot get into the liver because of high pressure in the liver caused by scarring and cirrhosis and portal hypertension. And that blood then has to bypass the liver and reach the heart and the systemic circulation again, and it looks to find alternative routes. And those alternative routes involve the opening up of porto-systemic anastomoses. This is retrograde flow up veins into small vessels that have closed down and that were functioning in fetal embryonic life and have now opened up again. And although they can happen everywhere, The commonest place for them, you can get them around your rectum and anus, you can get them around the umbilicus and the abdominal wall, you can get them around the spleen, but the commonest place is up around the lesser curve of the stomach and the esophagogastric junction and the lower esophagus. And these large varices or varicose veins, as they are, will develop in patients who have cirrhosis. And in about 1/3 to a half of these patients, when they've got varices, they will bleed. And usually they will bleed within 2 years of diagnosis of liver disease. And the first bleed has a mortality rate of about 20%. Okay, so it's serious. Because it's a major emergency, they lose a lot of blood very quickly. They become collapsed and shocked. And that is the thing that catches the eye. You're presented in the A&E emergency department with a collapsed patient who's vomiting large amounts of blood, clearly unwell. The key thing to remember is this, though. These patients also have sepsis, and they've got liver disease, and they've become septic, and the sepsis has raised their portal pressure and then triggered the bleed. They're coagulopathic. They may have electrolyte disturbances caused by their cirrhosis. They may have ascites. They may have renal impairment, and they may be encephalopathic. So think of scare: sepsis, coagulation, ascites, renal impairment, encephalopathy. There is a lot going on when people have variceal bleeding, and we need to pay attention to all of those things, not just the bleeding. So this is what varices look like. Here on the left, you've got esophageal varices, these convoluted bags of blue-gray worm-like structures. Here are varices in the upper stomach in the mid-panel, and very rarely you can get enormous varices like this in the duodenum here. And we know that some are more likely to bleed than others. It depends on the size of them, it depends on the pressure within them, and it depends on the severity of the underlying liver disease. Here are extreme varices, all from one patient here. And what you can see in the bottom right are these purpley or cherry red signs on the varices. These are signs of high pressure and impending bleeding. And in the top right panel, this varix has clearly bled within the last day or two. This little yellow thing poking out here that looks like a leaf, this is a fibrin plug that is sitting in a hole in a ruptured varix and stopping it from bleeding. And that's at high risk of blowing and starting to bleed again. So how do we treat these? Well, since the 1980s, Dr. Said invented a thing called the variceal band ligator. It's a device we stick on the end of the endoscope. It's a cap with rubber bands on it. And essentially we go down and we suck the varices in, and we then put rubber bands on them. So here's a patient here with big varices at the lower end of the esophagus that you can see. And we go into the stomach and there's a lot of blood around. Here we go, here's this coffee ground material and altered blood. And then what we do is we come back. Here's the banding cap on the end of the scope, and we find a varix and we suck it in like this. And when it's in, we turn a wheel and off comes a rubber band, and we ligate them, and that causes the bleeding to stop, and it causes the varix to thrombose and shrivel up. And we have 6 or 7 bands on the device, so we can go around and suck up all the varices and catch them that way. Sometimes variceal bleeding in the stomach can be torrential. Not the esophagus, but the stomach. These gastric varices are much harder to treat. And here is somebody here, and immediately is bleeding heavily. You can see this jet of venous, high pressure venous blood hosing into the stomach from this gastric varix. This patient could bleed to death within a few minutes. And in this patient, we're using actually cyanoacrylate glue, which is tricky stuff to use, so sort of rapidly setting plastic glue to just inject into the varix, and it will very rapidly activate and form a very dense cast, a plastic glue cast of the vein, and stop the bleeding. And you'll see that it gradually just stops within a minute or two. tries to start again, but stops. And so gluing is tricky to do, but is probably the one thing we do. We can either use glue or thrombin to treat gastric variceal hemorrhage like this. Sometimes variceal banding in the esophagus doesn't work. The patient keeps bleeding, and sometimes emergency treatment is necessary. And for about 50 years, we've used a thing called a Senstaken tube, which is a rubber tube passed through the mouth into the stomach, and then the smaller balloon here in the stomach is blown up, and the tube is dragged back manually until it's wedged at the esophagogastric junction, and it's kept there with traction outside the body. So there's this balloon pulling up on the diaphragm and physically squashing the varices closed and tamponading the bleeding. And that the patients nearly always need to be under a general anesthetic and intubated because they'll not tolerate the presence of the tube otherwise. And that's a holding measure that can buy you 6, 12 or 24 hours until you can do something else, or where you can transfer the patient to a bigger facility, a bigger hospital with more facilities to treat it. And the thing we would do if that happened is get them to our hospital and then place a thing called a TIPS. That is a transjugular intrahepatic porto-systemic shunt, a TIPSS. And so radiologists under X-ray would go down the vena cava into the hepatic veins. They would poke a needle through into the liver, and they would find a branch of the portal vein, and they would stretch up a tract. And on the right here, they would place a stent between the portal vein and hepatic vein. And that would allow blood to come up the portal vein, through the stent, into the hepatic vein, and that would drop the pressure in the portal vein. And that's been around for quite a few years, but it's not available in every hospital, but it really has to be available in centres that treat large numbers of patients with liver disease. And that's often a life-saving measure for recurrent variceal bleeding. So just remember that stopping the bleeding is difficult, but it can be done. And in fact, it's kind of the easy part. It's the technical part. But if you want a liver patient to survive, you have to get them to a high dependency area. You have to provide multi-organ support, especially kidney support, pay attention to their electrolytes and fluid balance. We need to give them antibiotics. These people, when they have a variceal bleed, very rapidly become septic, they get bacteria floating around, and antibiotics improve their survival. And we need to pay attention to their nutrition. After they settle down, we need to band them again and do the banding again and do it every week or every 2 weeks until the varices have completely been eradicated. And then we put them on a beta blocker, a non-selective beta blocker like carvedilol or propranolol at low doses, because that reduces splanchnic blood flow and it reduces the portal pressure and the chances of these varices bleeding again. So we're going to move on to a polling question here, and Priyanka will pull up the question, and that is that in patients presenting with an acute variceal hemorrhage, we should transfuse them to a hemoglobin of about 110, or during the bleed we should treat them with a non-selective beta blocker. We should treat them with the IV antibiotics. The mortality from a first bleed is 50%. Or E, the first thing we should do is put one of these Senstaken tamponade tubes down. What would you do? Which of these is the correct answer? We'll give you another 10 or 15 seconds. Okay. Will it be 49%? Will we do better? Here are the answers coming now. Okay, so 2/3 of you opted that during an acute variceal bleed, you would put a Senstaken tube down. Well, I would say that that's a good answer if you're in a hospital where you don't have endoscopy facilities. But other than that, that would not be the right thing to do. The correct thing to do, I would say, is C, give them antibiotics. So they come in the door with a variceal hemorrhage, antibiotics will reduce morbidity and mortality. We don't want to transfuse them too much. If you boot them up to their hemoglobin up to 110, you paradoxically just raise their portal pressure even higher and they bleed more. So running them at a hemoglobin of 70 or 80 is perfectly good and the right thing to aim for. Beta blockers, good later down the line. But if a patient's actively bleeding and hypotensive, then we would probably temporarily withhold the beta blocker until we'd sorted out the acute bleeding. The mortality from a first bleed, as I told you, is 20%. And balloon tamponade comes further down the line. Endoscopy should be the first thing you do once you've stabilized the patient. But I accept that depending where you are, balloon tamponade may be the only thing you've got available at that time. So next question. There's a double negative here and I apologize for that. In patients with acute variceal hemorrhage, which of these is not associated with improved survival? A, which doesn't help your survival? A, antibiotics. B, proton pump inhibitors. C, vasopressin, that's terlipressin, or somatostatin analogs. Or E, urgent endoscopy with banding. So, just a few more seconds. And the answers will just come up any second now. Okay, so third of you got the answer correct. The answer is that proton pump inhibitors don't really do anything in, unlike ulcer bleeding, in variceal bleeding, PPIs won't do anything terribly much. Priyanka, could you just put those answers back up again? Is that possible from the poll? Antibiotics improve survival. Terlipressin improves survival. In some countries, terlipressin is not licensed and therefore somatostatin analogs such as octreotide are used. I think the evidence is not quite as strong as terlipressin for their benefit, but they are used and they do reduce bleeding and improve outcomes. I just haven't mentioned that in my talk. That was a slight googly, I've bowled you there. But the correct answer there is omeprazole. It doesn't really do anything for a variceal bleed. Thank you, Priyanka. I can close that. So in summary, end of the lecture here for this bit of it. Mortality from GI bleeding is still a major problem. Remember that most deaths, whether they're variceal or non-variceal bleeds, are not directly due to bleeding. They're due to the comorbidities and other conditions that the patient has. And the improvements in treatment are possible through resuscitating people, risk stratifying them, timely endoscopy, restrictive transfusion, don't stop the antiplatelet agents, and have embolization available if ulcer bleeding therapy fails. So here's a case. We'll spend a few minutes. I hope everybody's okay and still awake. Not too long to go now. You've broken the back of this. Here's a 70-year-old man. He presents with hematemesis and melena and syncope. He's hypotensive, he's tachycardic, and his hemoglobin's only 85 grams per liter. And his urea's raised. Remember that your blood urea is a marker of how much protein you've absorbed from your gut. And in a GI bleed, you dump a lot of protein-rich blood into your gut, you absorb it, can metabolize to urea breakdown, and you know, is measurable. So the higher your urea, the more is a sign of bleeding. He had been on holiday a year earlier. He'd been found collapsed in the hotel by his wife. He'd had a cardiac arrest and needed resuscitated by the medics, the paramedics. He had had an NSTEMI, a non-STEMI heart attack. He underwent coronary angiography and he had a severe stenosis in his LAD, and he had drug-eluting stents inserted, and he was started on aspirin and clopidogrel. He was an ex-smoker, he's got high blood pressure, and like most people from Scotland, he's got high cholesterol levels. So polling question number 5, what would you do next? Rush him to theatre for a laparotomy to find out why he's bleeding? Do an endoscopy within 6 hours? Would you transfuse him 3 units of blood and then do an endoscopy? Would you fluid resuscitate him in a high dependency unit, or would you keep him in the ward for a few hours, check he's okay, and then allow him home if he's stable? See what everybody says, give you a few more seconds. And the answers will be with us now. Okay, well done everyone, 39% got it right. So keep those up please, Priyanka. So the correct answer is D, fluid resuscitation in a high dependency unit. You want to resuscitate the patient with clear fluids, with crystalloid, get him to a place of safety where he can be carefully monitored. You wouldn't dare send him home. He's at high risk of a bad outcome. He's had a significant bleed. If you give him 3 units of blood, well, you know, that's a liberal transfusion policy and that might affect his ultimate outcome. Would you scope him within 6 hours? No, there's no evidence that it's of benefit. You need to stabilize the patient, resuscitate them, get them in a good optimum condition, and then we'll do the endoscopy within 12 to 24 hours. Okay, thank you. What would you say this risk, the patient's risk of death was from this sort of story and this clinical presentation? Is it low, less than 1%? Is it medium, 1 to 10? Or is it high, over 10%? I'm going to give you another 10 seconds for this, and then because it's a pretty straightforward question. And here come the answers. Well, you've all opted, half of you, for medium. I think it's a slightly naughty question from me. There isn't a hard answer here. I would actually go with the 44% who opted for more than 10%. This man is elderly. He's got a bad heart, hypertension, hyperlipidemia. He's had a cardiac arrest. He's got coronary stents. He's on dual antiplatelet therapy. He's had a decent, good size bleed. He was hypotensive and tachycardic when he came in. Thank you, Priyanka. And I would estimate that his mortality rate is higher than 10%. And so when we add all these up using the Blatchford score, melena, syncope, hypotension, tachycardia, all the things in orange there, his Blatchford score is 16. That's a bad bleed and highly likely to need an urgent intervention and with a significant risk of death. So this is what we found. There's that artery sticking out the ulcer with active bleeding here on the right. We injected it with adrenaline, we heater probe cauterized it, we gave him an IV PPI for 72 hours, we biopsied his stomach to find out if he had Helicobacter, and it was actually negative, and he settled down. So for this patient, here's the final question, and I'm sorry if it's a little bit repetitive, but I think it's worth going through one final time. The polling question, please. Kritika, Priyanka, thank you. So for this patient, would you stop both his antiplatelet agents for a month? Would you stop them for 7 days? Would you keep them both going right through this whole thing? Or would you keep the aspirin going, but maybe stop the clopidogrel, have a chat to your friendly cardiologist and work out a plan from there? So a few more seconds to think about that. Good, well done. So 3/4 of you opted to keep the aspirin going, but stop the clopidogrel and discuss with a cardiologist a plan for reintroducing them or what to do. And that is the correct answer. So if you keep the aspirin going, he'll get some antiplatelet benefit. His stents will be at less risk of in-stent thrombosis caused by cessation of the antiplatelet agents. You can keep off the clopidogrel, and the cardiologist can look at the angiograms and the past history and tell you whether in fact you think you need to restart the clopidogrel or whether it's safe to just keep the patient on single agent. Thank you. Let's close now. So in the UK, we put all this together, and this was published last year. And again, you could look for this in Frontline Gastroenterology. It's free to download, or you can take it from this slide. But this is the care bundle. A care bundle is a package of measures put together to be used in a hospital setting. And if you do all of these measures together, they address quality and quality improvement and outcomes. And this is the 6 R's that I mentioned a long time ago at the beginning of the talk. So we want to recognize the patient's had a bleed. We want to resuscitate them. We want to risk assess them. We want to treat them. That's the RX medical language. We want to refer them to specialist gastroenterology. And then we want to review afterwards and make a plan. And there are boxes down the right to help you with the prompts, with the things you ought to do. And that simple scoring sheet bundle should help improve the mortality and the outcomes of people with upper GI bleeding. So remember, it's important to target the bleeding, but let's not miss the point. It's the whole patient that matters. And you'll find out lots more about it in the fabulous Davidson's Principles in Practice in Medicine textbook from Elsevier. This is the city where I live. I've never actually seen it look this good, but that's what professional photographers tell me it looks like. It's a lovely city if you ever get a chance to visit, and I'd be very happy to take some questions. Well, that's exactly an hour, but I think we could run on for 5 or 10 minutes if that's okay, and I'll try and take some of the many questions that you've answered. Thank you very much, everybody. So
yes, Dr. Penman, so we can extend it for a few minutes and you can do the Q&A now.
Okay, so I've pulled the Q&A up on the screen. Is that okay? Will I try and bash through this as quickly as I can? So Malapati, difference in color of blood between melena and hematemesis is due to the enzymes and acid in the lumen of the GI tract digesting the blood, and enzymatic breakdown of hemoglobin, and the heme changing color and becoming oxidized to hematin, and therefore gradually going from red to purple to black. Can any autoimmune cause lead to non-variceal bleeding? From Sunil. Tricky one. I might answer that one later, Sunil. I don't have an answer to that. I'm not sure of any autoimmune causes of non-variceal bleeding off the top of my head. Edison asks, oh, it tells me in India use the modified early warning system. Okay, the early warning score. That's great. So it's probably very similar. Good to know. So as I said to Sunil, I mentioned that we don't know why restrictive transfusion is associated with a better outcome. It's something about blood. It's immunogenic, it's foreign, you know, it's not from you, it's pooled from other people. It's antigenic, immunogenic, it may be pro-inflammatory, it may be pro-thrombotic, and that may not cause a problem for, I don't know, 2 weeks, 3 weeks, 6 weeks. But it is interesting the number of people who survive a bleed, go home, we think that's the end of the matter, and then we find out that 3 months later they had a stroke, or they had a heart attack, or some other problem. Pulame, kindly explain the meaning of exsanguinating. An exsanguinating patient is a patient who's just bleeding so heavily that even though we put IV fluid in, crystalloid, saline, blood, we cannot keep the patient's blood pressure up. Their blood pressure is constantly dropping. They're hypotensive, they're shocked. They may be heading towards a cardiac arrest. That is an exsanguinating patient. I'm just going to move these questions. With a loss of blood, there's a loss of oxygen. How is IV colloids helpful? Well, as you may know, Sri, there's quite a lot of debate in the intensive care literature about the pros and cons of different types of IV fluid. And I think it is not clear at all what is the best fluid to use. Some starch expanders, some colloid fluids have been associated with worse outcomes in intensive care units and in trauma and in major surgery. And therefore crystalloid fluid is preferred. So crystalloids such as saline or plasma-like Hartmann's solution are probably less harmful. They don't carry any oxygen, you're correct, but at least they expand your plasma volume and they allow your cardiac output to be maintained. The placebo, what was the placebo? Well, the placebo is just placebo, it's just chalk tablets in that study. What alternative, Ashley, Mary Thomas, is typically given for peptic ulcer patient instead of aspirin? Well, you can restart the aspirin after a few days. And if the patient is given a proton pump inhibitor, there is no evidence that aspirin prevents the ulcer from healing. So if they're given a PPI alongside their aspirin, the ulcer will heal in the majority of patients and bleeding will not recur. So usually we would give them aspirin. I think if you have no choice but to stop the aspirin, then you could use something like clopidogrel. On the basis that clopidogrel is a strong antiplatelet agent, but it isn't mucosally damaging. Aspirin, as you know, is similar to non-steroidals and causes erosions and ulcers in the gastrointestinal tract. Sunil has asked, what did that Hemospray nanopowder contain? And the answer is, we don't know. It was developed by NASA and in the scientists in the USA, and its exact makeup is still an official secret. But it is biologically inert. The chances of recurrence of bleeding after cauterization, probably less than 10% if it's done properly, Kartik. And Kirti, don't the metal clips develop into foreign body giant cells? That's very interesting. No, they're titanium or titanium alloy. They are biologically inert. The little clips usually fall off within a few days or a week and are just naturally passed through the gut without the patient knowing it. But they can stay there for a long time. They cause a little bit of tissue hyperplasia around them, but we don't tend to get a foreign body reaction around them. But it's a very good question. Minakshi Mukhopadhyay, why to avoid NSAIDs in the post-endoscopy plan? Well, because NSAIDs cause ulcers. They damage the stomach lining, they damage the duodenal lining, and they will do it again. And it's probably better not for patients who've had an NSAID-induced ulcer not to be given them again. It's due to their COX inhibition, and COX enzyme's important for maintaining blood flow and mucosal integrity. And if you knock out cyclooxygenase, COX enzyme, you get ulcers. Can we operate endoscopic treatment people on amantadine flu pills? Absolutely. I don't see any intrication with that. Guaiac test, Adarsh, we wouldn't use that in testing bleeding. If somebody comes in and there's a complaint of melena and you do a Guaiac test on the stool, it doesn't really help you. Usually you can see melena, you can certainly smell melena, and if you see a normal stool and test it, you'll find quite a lot of people are Guaiac positive just because they've had one drop of blood in their stools from brushing their teeth or something they ate, and therefore there's no role for using the Guaiac test in acute GI bleeding. Palab, Sarkar, does clopidogrel induce bleeding? Well, yes, it does. It's a very potent antiplatelet agent, but it doesn't cause ulceration, as I've said, like aspirin. So there is an argument for possibly changing it. Where are we now? I think I may have pulled these questions up too quickly. They seem to shoot up and down. Here we go, here we go, here we go, here we go. I'm just bringing that, sorry about this. Hold on a second, I'm pinging through. There's thousands of these questions. I'm going to get through a few more. Which one to prefer, more esophageal band ligation? Well, if you have an endoscopy unit, or access to endoscopy, then band ligation, endoscopic band ligation is the #1 treatment. Balloon tamponade is potentially dangerous. If you inflate the balloon in the esophagus, you can perforate the esophagus. And TIPS, you're shunting blood away from the liver, so it's a good rescue therapy, but people can become encephalopathic. It's expensive, it's difficult, so it would be kept further down the line. Adiraj, I've talked about COX-2 inhibitors. Okay, antibiotics, we've talked about how to differentiate between esophageal bleeding and upper GI bleeding. Well, it's very hard. You have to do an endoscopy to find out. Why is coffee ground vomit? Coffee ground vomit, I don't know. There may be small amounts of blood in it. It may be what the patient ate. It may just be acid digesting whatever we ate. But frequently people's vomit is brown. It does not mean that they've had a GI bleed. Okay. Yep, you can get variceal bleeding in children. Usually it's because, you know, chronic liver disease is rare in children, but they may have congenital liver problems, or they may have a condition that predisposes them to portal vein thrombosis. And if they've had a thrombosis in their portal vein, blood can't get up to the liver, they develop varices. Okay. Autoimmune vasculitis, Puneet, can cause GI bleeding. It's rare, but it's a good point. You can get it in lupus and other causes of vasculitis. The News criteria we've talked about, and in India, we heard you use the Muse criteria. I think if you Google it, you'll find the answer quite easily there. Blood transfusion, it is concentrated red cells that we're using. So PPI drugs are of use in ulcer bleeding, Avniendra, but they're not of real value in variceal bleeding. Why would acid-lowering agents work for variceal bleeding? Okay, vasopressin actually in the acute setting causes splanchnic vasoconstriction, so it reduces the inflow into your gut blood system, and therefore it reduces the amount of blood coming up the portal vein, and therefore it reduces the portal pressure. But it also helps by being a general inotrope and raising blood pressure. Okay, so antibiotics, we don't know why it is, but in variceal bleeding, the bleeding episode seems to be associated with translocation of bacteria from the gut lumen into the blood system. You know that liver patients are immunocompromised. They don't make a good immune response. They're very fragile patients. They're easily tipped over the edge, and they frequently have gram-negative sepsis during an episode of variceal bleeding. And broad-spectrum antibiotics like piperacillin tazobactam or coamoxiclav certainly improve survival for that reason. People don't become allergic to clips. Sclerotherapy, where you inject a sclerosing agent, is good for varices. It's simple, it's cheap, it's old-fashioned, but banding is simpler and safer. How are we doing for time? I've still got lots of questions here, but
what we can do, Dr. Ryan, we have more than 200 questions here. We can take we can take 2 or 3 more.
Okay.
If you can see any important ones, and the rest of the questions, as mentioned by you earlier, we can address them through email. We can share the questions with you, and we will address all the unanswered questions through email with all the attendees.
Thank you, Kritika. Thank you. Okay, well, I'll carry on for 2 or 3 more minutes then. So why are variceal patients more prone to sepsis? I've just explained that. It's usually gram-negative bugs. Here's a good one from Kartik. Is tranexamic acid used? Now, tranexamic acid, for those of you who don't know, is an antifibrinolytic. So when you make a fibrin plug as the first reaction to bleeding and you get a clot forming in a fibrin plug, tranexamic acid stops that plug from breaking down, okay? And it stabilizes it. And we hoped that tranexamic acid would be good in ulcer bleeding, but in fact, a huge trial called HALT IT was published in the Lancet journal just about a month ago, and it shows not only was there no benefit to tranexamic acid in ulcer bleeding, but in fact, there were more deaths and poorer outcomes when people were giving tranexamic acid. So very, very recently, we have now stopped using it. Yes, isosorbide mononitrate is a useful add-on drug with beta blockers and band ligation, amlan, Chowdhury. Yes, that's a good point. Sai Manikanta has asked how to deal with gastrointestinal bleeding from an obscure source. An obscure source is that you've done an upper endoscopy and not found anything. If it's been melena, then you have to think maybe it's a colonic bleed. and therefore you would do a colonoscopy. If that was normal and you've got a normal upper and a normal colonoscopy, then we would leave it alone at that point. But if it happens again, we would do a small bowel study. And there are lots of ways you can do that. Probably the best test is one of these small bowel capsule endoscopies, if you've got access to that, to look for obscure vessels in the small bowel that are bleeding. Okay. Steroids do cause steroids can cause gastric ulcers, yes, and what they do really do is they prevent ulcers from healing, so you can get steroid-induced ulcers. And I'll take 2 or 3 more. Yeah, a lot about clopidogrel instead of aspirin. It's not a bad strategy. Okay, balloon tamponade, no, we've talked about. When do you call a surgeon? This is the one from Edison I'm going to end with. When do you call in a surgeon to manage an acute upper GI bleed? Well, that's a really good question. Even in our large 1,200 bed hospital, which is an esophageal-gastric cancer surgery and trauma hospital, our surgeons now operate on a bleeding ulcer about once every 2 years. Endoscopic therapy has become so good, and rescue therapy with radiology and embolization has taken away the need for surgery nearly all of the time. However, you should have a surgeon available. And if you don't have endoscopy, if you don't have interventional radiology and embolization, or these methods have failed, that's when you should consider surgery. However, no surgeon appreciates being called at the last moment when the patient is about to die. And I think if you're in any doubt, and depending on your local facilities, it's always good to talk to the surgeons early. So if you've got a person with a big bleed and they don't seem to be doing very well, or there's going to be a delay to endoscopy, or radiology is not available, then go and find your surgeon early and even have a conversation so the surgeon's aware. I've got this patient here, we're going to do this, we're going to do that, but I may need to come back to you if things don't improve or settle down. So discuss it with them early so that they can be prepared to deal with a bleed. Antibiotics, aspirin, I'm just scrolling through these. And last one, the management of a Mallory Weiss tear, clipping. Clipping is the way to treat them. Okay, so I'm going to stop there. You've been brilliant, and I'm really grateful that you allowed me to spill over for an extra 15 minutes. I hope you've learned a few key tips there on how to manage your GI bleeding patients. And I will try and answer as many of these questions by email online after we've done this in the next few days. I hope everybody stays safe, you and your families and colleagues in India. I hope this terrible COVID goes away soon. My thoughts are with you all. Stay well and enjoy your studies.
Thank you, Dr. Penman, for joining us today and for such a knowledgeable and insightful session. I'm sure the students will get a lot of benefits out of these. We have more than 230 questions. As mentioned, we will try to address all the questions through email with all the attendees. Apart from that, we'll be sharing the e-certificates with all the participants today over the email, along with the recording of this session. And also we are looking forward to everyone to join us tomorrow for another masterclass on making the correct diagnosis of diabetes by Professor Mark Stretchman.
Thank you. Professor Strachan's brilliant. You mustn't miss it.
Thank you so much. Thank you so much for saying that, Dr. Penman. Thank you again. And thank you everyone for joining us today. Thank you so much.
Take care, everybody.
Thank you.
Bye-bye.